second or two for everyone to log on. I know everyone's trying to figure out the app here, so we will give it a second or two. You'll get the hang of it. All right. Well, I don't want to take any more time because we got to get to the keynote soon. So hello, everyone. Welcome to the Millennium Alliance Healthcare Payer and Provider Transformation Assembly. We hope that you are all staying safe during these times, and we are so glad to have you here at our event. Some of you have joined us before in person, and others are connecting with us virtually for the first time, but rest assured, we have a great 2 days ahead of us. I just want to go over a couple of housekeeping items before we get started and as people are logging in. You should have received our event app tutorial video, and we're confident it's going to be easy to follow along with your schedule and attend the workshops and the meetings that we have personally scheduled for you. So if you do need to take another look at that video, you can revisit that over on our homepage. You're going to hear this a lot throughout the next 2 days, but filling out our survey feedback forms after each session is going to be extremely important. Obviously, we're all trying to learn during these virtual times, and so any feedback or comments that you have would be greatly appreciated after each session. And you'll be able to find that when you click into each session. It's at the bottom of your screen to submit feedback. And finally, if you do have any questions throughout the virtual event, you can always connect with us through the Help tab. Our client services team is working diligently on the back end to make your virtual event experience run smoothly. Now, we're going to kick off this assembly. I am very excited to announce our opening keynote speaker, the former CMIO at Kaiser Permanente, John Mattison. He has led the design and implementation of the largest integrated electronic health record in the US and leads various national programs, including virtual care. And today, John is answering all of the COVID-19 questions you've been wanting to know, but were afraid to ask. So John, I'm gonna turn off my screen and let you take it from here.
Great, thanks so much, Kara, and welcome everybody. I look at the attendee list and a pretty impressive group of folks on the call here. So I look forward to the Q&A. I'm gonna try and race through a lot of content fairly quickly in order to save some time for Q&A. So please fire your questions off on the text so that we can get to them towards the end. So what qualifies me to be speaking on the topic of COVID, other than the fact that we're all obsessed with it because of its impact on our lives. I was a marine biologist with a focus on evolutionary biology before I decided to go to medical school, and have kept a very active interest in infectious diseases, evolutionary biology, and epidemiology ever since then, and very active in the genomics space, chaired one of the work groups, the Global Alliance for Genomics and Health. And I've been intensively involved in following the science closely since the onset. We've only had 7 months of knowing this virus, and yet there are almost 40,000 research papers published since the onset of COVID, and I've read every single one of them. Not possible. Nobody has read every single one of those. So the knowledge base for COVID has been distributed across many minds and many domains. I like to think of, and back in February, I coined the term whack-a-mole pandemic, because if you look at the biology of the virus and you look at the lack of herd immunity that we started off with, it was inevitable that we were going to see exactly what we're seeing now, where you implement the non-pharmacologic interventions like social distancing and masks, and you suppress the spread. People fatigue on that, and you relax those sanctions, and it comes roaring back. And there was no question that that's how this pandemic was going to play out from the very outset, just in the basic biology of the virus, and based upon the psychosocial characteristics of populations. So one of the big distinctions between, why did the Far East and Germany do so much better than the US initially? It's because they have much greater trust in government. And as a result of having much greater trust in government, there was much better compliance. And the US is kind of an outlier, particularly recently in trust of government. And it has affected us in a very predictable way. So the whack-a-mole applies to everybody globally, but it's going to be more pronounced in the US because these issues is fairly relatively unique on a global basis. So I'm going to run through a couple of quick true-false questions and then get into some examples of cognitive bias and how there are a lot of myths still circulating that are based upon various cognitive bias. And my screen kind of went blank. Just to process check. Are you able? Oops.
Yep, we're trying to put you back here.
Can you still see me or no?
We can't. Did your video turn off?
My video turned off. I don't know. I had an incoming that somehow disrupted it. So it's okay. I can't see video, but as long as you can see video, I'll just keep rolling. So you're good at your end?
No, you're just gonna have to hit your start video button.
It says you cannot start your video because the host has disabled it.
All right.
When I hit the start video button, it won't.
All right. If you want to keep talking, we'll put your screen back on.
Okay.
Sorry about that.
So no worries. I learned something new about Zoom. If you have an incoming call linked to your cell phone on your iPad and an incoming call comes, it does this. So that's the first time I've ever experienced this. Sorry, apologies to all. So true or false? If your antibody test shows good antibody levels, you're probably immune to the disease. Okay, the answer is false. There are a couple of reasons. There are different antibody tests, some of which are neutralizing antibodies, some of which have no biologic or clinical significance, and antibody tests are notoriously inaccurate. So a positive test does not guarantee that you're safe, particularly with the low prevalence of the disease now, low being in the 3 to 5% range. When the prevalence of the disease hits 80%, simple Bayesian mathematics, the probability of a positive antibody level being a true positive goes up dramatically. But right now, with a relatively low prevalence, a positive test doesn't mean anything. Do not assume that you're immune. Number two, if your antibody test is negative, you do not have any immunity to COVID. The answer again is false. What we know from a series of papers, one of which Tony Fauci held up at congressional testimony, literally held the paper up in his hand back on Friday, just a couple days ago, from the La Jolla Immunology Institute, shows that a lot of people have evidence of T-cell reactivity to the virus, even though they don't have any antibodies. So next, if your PCR test is negative, there's a small chance that you're infected. Okay, that's also false because of sampling error. It depends upon where the virus is located in what viral load at a particular point in time and what area is sampled. So if you sample the nose late in the disease, it may have already been eliminated from the nose and yet is fulminating in your lungs. Next, if your PCR test is positive, you're almost certainly contagious. Again, another false. And the reason for that is that fragments of the virus may persist for a long time after you've recovered and defeated the virus. And the PCR test will detect fragments, but there may not be live virus that you can culture in vitro. The live virus cultures are too expensive, so they're not routinely done. Number 5, we'll likely have a vaccine ready to go by the end of this year. Okay, the answer in my estimation is true. I have felt like that was likely to be the case all along, not because of the historical trends. The historical trend is it takes years to develop a vaccine like this. But what I anticipated is that, in fact, we would have a global collaboration and pre-publication prior to peer review that would accelerate the whole research process every step of the game. And many of these companies have either been funded or have put up their own money to scale production of their vaccines before they even enter clinical trials. So there's lots of things because of the imperative to really move quickly that have overcome some of the time burdens of bringing a vaccine to market. And as I'll discuss a little bit later, the recent studies on T-cell immunity have significantly informed our ability to be able to judge which vaccine is effective much earlier without having to do a challenge test. Now, in influenza, they do challenge tests with the live virus, but that's considered unethical because of the severity of the disease associated with COVID. So we won't have the advantage of having live virus challenges as we do with influenza, but we have a good proxy for that. Has not been proven, but T-cell testing is going to play a huge role in that. So number 6, if you've already had COVID, you probably have at least a few years of immunity from that recent exposure. The answer is that's probably true. It's too early to know. The last true-false question. Hydroxychloroquine has been proven not to work. The answer to that is unfortunately false. And I coined another term related to this epidemic. So back in the 70s and 80s, there was a drug given to all pregnant women who had the nausea of pregnancy. And there we go. You should have the video back. Nearly every woman who had nausea took the drug, Bendectin, and any one of them who had a birth defect sued the manufacturer, claiming that the drug was teratogenic. There was not a shred of evidence that the drug was teratogenic and causing birth defects, but they took the drug off the market. The New England Journal of Medicine coined the term litogen. So they called Bendectin a litogen, that it caused litigation as opposed to birth defects. It was taken off the market as a consequence of it being a litogen. My view is that very prematurely, hydroxychloroquine was taken off the research agenda because it's become a politigen in that it is generated and followed course with a tremendous political polarization we have these days. So what study would be necessary to prove whether or not it's effective? That would be a study where it's given at the earliest possible moment, because as we know, all antivirals, antibiotics, antiparasitic drugs, antifungal drugs, all of them are by far most effective early on. And there's good reason to believe that an early administration of hydroxychloroquine has a chance of working. I'm not saying it does. But that study was designed, and that study was launched by the head of infectious disease, multi-institutional study, the head of infectious disease at Diego. But the study could never be completed because by the time they got the study rolling, it had already become a politigen, and they couldn't enroll any patients. No patients were willing to enroll in something that was declared ineffective, when in fact the trials that showed it was ineffective in later stage disease, and 3 to 5 days after exposure in a post-exposure prophylactic study that is much heralded as the answer, it's never been given early enough in the course of disease to prove that it doesn't work. Again, I'm not saying it does or doesn't. It's just that it became a politigen and impossible to study it because of lack of enrollment volunteers prior to the definitive study being done, which was funded, launched, and then aborted after it became a politigen. So now I'm going to shift gears. I'm going to talk about sort of the myths associated with COVID, and there's so many that I won't be able to cover them all in this conversation today. But one of the things that, so I've been deep in machine learning for a long time, stood up the machine learning team at Kaiser Permanente, and one of the things that people fret about with machine learning is the intrinsic bias associated with machine learning. There are many intrinsic biases, 2 books written on that topic. What is, and that's fortunate because they're real and they can be mitigated. What's unfortunate is that, and I've asked, giving a keynote like this to 1,000 physicians, how many physicians had more than 1 hour in the course of their training on cognitive bias? And 0 hands went up out of 1,000 physicians. So there are over 130 types of cognitive bias that affect our judgment about what to do in a given clinical situation or any decision situation. It's a very mature science, and yet it's not taught and it's not practiced. And we've seen evidence of numerous cognitive errors associated with management of the COVID. So the first myth, the case fatality rate is a constant. So the fact is that it depends. So the case fatality rate in the absence of any pharmacologic or non-pharmacologic intervention is in fact a feature of the virus that is a constant. However, when you introduce social distancing and masks and all the things that Germany and the Far East and Taiwan and Singapore have done so well to such great benefit, those dramatically change the case fatality rate. So the cognitive error there has to do with what's known as ascertainment bias. So when you initially discover any new disease, whether it's an infectious disease or a rheumatologic disorder or a cardiac disorder, we always recognize only the extreme cases at the beginning, and we don't see the scope of disease until much later on. And with that being the most extreme diseases, the case fatality rate and the morbidity and mortality of any new disease is falsely elevated because we haven't understood the scope of disease. As we have learned that there are many asymptomatic infections, we can now say that the case fatality rate is much closer to this is the CDC modeling, much closer to 0.3 or 0.5% than it is to the 2 to 3% that was initially reported. So the second myth is that children don't transmit the disease. So it's safe to send all of our children back to school in September. And that when we send children back to school, that's the main consideration. The fact is that even children without clinical symptoms have been shown to have residual lung disease months after they were asymptomatic with an infection with the virus. And there's recent studies showing that that's also true for the lungs of adults, as well as echocardiograms of individuals who have been through COVID, that months later, there's evidence, substantial evidence of a high prevalence of both residual lung and cardiac disease. So the error there, and also it's not the children themselves we worry about as much as we worry about the parents and the grandparents that they go home to, and the school teachers who are exposed to them. So the cognitive error there is confusing, and this is the most common one in the COVID example, is that there's a confusion between absence of evidence without good studies with evidence of absence. And so when the senior physician at the World Health Organization declared that children don't transmit the disease a month or two ago and had to walk it back 2 days later because of the uproar from the scientific community, that individual was mistaking absence of evidence for evidence of absence. So increasingly, we were recognizing that the viral load in children who are asymptomatic is as high or higher than it is in adults. And there's no reason to believe that they don't transmit the disease in the same way that adults do because the viral load is so high. The third myth is that transmission is due to just large droplets. So 6 feet, 6 minutes, no worries. If you look at the modeling, there's been very sophisticated machine learning modeling of how the disease was transmitted on the initial cruise ship, the Princess cruise ship. And what they've shown is that the droplet hypothesis cannot possibly account for the way the virus spread through the cruise ship. And that in fact, very, very small aerosolized particles are significant. So is there proof of that? No, but the modeling is pretty compelling. And the cognitive error there is, again, mistaking the absence of evidence for evidence of absence. The fourth one is pregnant women have nothing to worry about, that they're relatively protected. The facts are that, and we've known forever, that pregnancy is a relative immunosuppressive state, and there is increasing evidence that you are not relatively protected when you're pregnant. So again, mistaking absence of evidence for evidence of absence as it occurs. The sixth myth is once you recover from COVID, you're out of the woods. If you Google COVID long haulers, you will find a growing stream of scientific reports of long-term consequences to people who had an otherwise full recovery, where there's chronic fatigue or cardiac issues or pulmonary issues, lots of different issues. I personally have used virtual care to manage dozens of people with COVID, friends and colleagues globally. And I've seen a very high prevalence of long-term problems in 20, 30, and 40-year-old patients suffering from the disease. So that myth, again, is related to the confusion of absence of evidence with evidence of absence. The next myth is that the transmission metric, the R naught, the reproductive factor, is a feature of the virus. The facts are that the population density and the non-pharmacologic interventions have a huge impact on R naught. So Angela Merkel, Chancellor of Germany, early on, because she's a scientist by training, explained to the public in Germany that the only way to manage the virus is to get R naught less than 1. And R naught is a metric of how many people are infected by the average person who has the disease. And the R naught of 2 to 3 that was seen in China initially can be managed down below 1. As soon as you get below 1, you're on the path to suppressing the transmission and the prevalence of the disease. And so R naught can be measured and can be managed down. The next myth is respiratory in nature. The fact is that the initial presentation and clinical course is highly variable, and I've seen this. And one of the infectious disease physicians, who's a friend of mine at UCSD, who has been managing the infectious disease wards at UCSD, which is a lot of the admissions during this upsurge, has said almost anybody coming into the hospital, the first assumption is rule out COVID because of the variability of the manifestation of the disease. And again, this is an absence of evidence, but now we know better that the manifestation and the presentation can involve multiple organ systems. And we're seeing a lot of non-pulmonary organ system involvement, whether it's the cognitive fog that people are getting from it, or the cardiomyopathy, or the pericarditis, or myocarditis. And one of the NBA stars was just, no, it was a pitcher, sorry, from the Red Sox, who was just taken out because he has myocarditis associated with COVID. So the variability presentation is something that is really underrepresented. And again, absence of evidence versus evidence of absence. So we're now seeing that there's abundant evidence that there's a wide diversity of presentations and morbidities. The next one is that COVID will magically disappear during the summer months. We now know that's not true. And the interesting thing is that in viral epidemics of the past, we've seen that the first year of many of these, including the Spanish flu, just flared throughout the summer. But then if it was a seasonal type of respiratory transmission, that it did become seasonal after the first year or two. So we may see a seasonality of COVID similar to what we see with influenza after this first year or two going through. The next myth is that after surviving the first wave, we're now experiencing a second wave of COVID. And actually what we're experiencing is much more of an extension of the first wave by virtue of the relaxation of the social distancing and masks and so forth. And so it's not really a second wave. Are we likely to see a second wave? Probably so. One of the fascinating things is in the Southern Hemisphere, where it's the traditional winter and hence the traditional flu season, we're seeing lots of COVID, just surges everywhere. South Africa and Australia in particular getting hammered with COVID right now. But they're not seeing a lot of flu. They're seeing a lot less flu. And so there's a lot of theories about why is that happening? Is there a direct link between COVID and influenza viruses where it's displacing it? No one knows. But it's most likely that the aggressive social distancing measures taken in the Southern Hemisphere may well have been more effective for influenza than it is for COVID. So COVID is roaring through and the herd immunity for flu is higher in vaccination programs and so forth. So it may be that the non-pharmacologic interventions have been more effective against the flu than they are against of the disease and the progression of herd immunity. And from the very beginning, I've believed that one of the tremendous silver linings of this pandemic is that we're going to learn how to manage the flu better. I mean, people come to work every year with fever and cough and sneezing and infect everyone in the workplace with influenza and don't take out of it and shake hands in the middle of influenza, which is craziness. And so we're going to see some collateral benefit of all these social distancing procedures with influenza in the future. I think we're already seeing that in the Southern Hemisphere. The next myth is that after surviving, the last one is that young and otherwise healthy people have nothing to worry about. And what I can say about that, and I've already alluded to it, is Google long haulers, and you will see a literature that is very compelling that young people may have they do have much less risk of being admitted to the hospital, intubated, ventilated, and death. But that doesn't provide them immunity from some of the long hauler consequences to the extent that one would expect. So I'm going to stop there and open it up to Q&A. So Kara, if you want to, and please submit your questions. We've got some time left for some Q&A. I'd love to hear what all of you are thinking. It's a pretty august group of people who are attending this webinar. So take it away, Kara.
Sure. We're just to confirm, we are in the chat over on the event portal. We're not using the chat in Zoom. We did get one question starting off. Should we anticipate another significant peak in the fall with flu season, which you talked about a bit?
Yeah, I think it's very likely because of the same reasons that we see the seasonality of influenza. Until we get a good vaccine, which I do believe we will have by the end of this year, and then the vaccination campaigns can start. The herd immunity is not going to be anywhere near what it needs to be in order to prevent that from happening for all the reasons that influenza flares up in the fall and winter. So, no one can be sure about this, but there's good reason to believe that we'll experience a true second wave in the fall associated with the winter weather pattern. There's lots of hypotheses why that's the case. My own hypothesis is that in addition to what's known about survival of the virus being better when the environment is cooler and people being clustered indoors more during the winter, which are both plausible hypotheses, my belief is that the first line of defense of the immune system is in the nasopharynx. And in the nasopharynx, there's a whole ecosystem of immunity. And we do know that immune cells are benefited by fever. And teleologically, from an evolutionary biologist perspective, the purpose of fever is to fire up your immune system. You wouldn't want your immune system to be fired up all the time. So you fire it up when you get an infection. And we know that the immune system is activated by a warmer body temperature. During the winter season, when we're breathing cold air, our upper respiratory tract is significantly cooler. And my hypothesis that's yet to be tested to my knowledge with any scientific study is that the early warning system in the nasopharyngeal area is subject to cooling and relative disabling of that early warning system to rev up the systemic response to an infectious pathogen associated with the colder winter season. That completely hypothetical, but there is no solid scientific evidence about why viral infections that are transmitted through the respiratory system flare in the fall and winter season.
John, we did get a couple of questions about kids going back to school and what do you think will happen on the major college campuses? And is this going to increase the numbers?
With the flares going on throughout the South and the Southwest and now the Midwest, there are already schools that have opened and shut down days later as a result of infections. Teachers' unions are very, very concerned because sure, the kids are not nearly as adversely affected as adults. But what about the teachers? If you're a 60-year-old third grade teacher and you're being told you must come to work because it's safe for the kids to come, well, what about you? And what about the children taking the virus home to their parents and their grandparents? And particularly, the essential workers who are at the lower end of the socioeconomic scale frequently have multi-generational households where the third graders are coming home and exposing their grandparents to their asymptomatic carriage of a high viral load of COVID and infecting them. So my own personal bias is that getting children back to school is critical to restart the economy because the parents can't go to work. Childcare is more of a problem than is school. It's safer for a child to be at school in most cases than it is with social distancing procedures in place than it is to put them in childcare. And so there is an imperative to get people back to work and an imperative to get their children back in school to restart the economy. But like everything else we've witnessed so far in this pandemic in the US and Brazil and other countries that have managed it poorly, is that if you act too quickly, it backfires and it relaunches another surge of the virus, hence the term whack-a-mole pandemic. So my personal bias is that we must get children back to school so parents can go back to work in order to start the economy, but it's too soon right now, particularly with these flares going on in the US as a result of the psychosocial fatigue on the social distancing. So I personally don't recommend sending children back to school right now, but because that's such a politically loaded topic and because there is a severe consequence of the economic slowdown, people losing their jobs, people not being able to pay their mortgage, being evicted from their homes. This is a real tough one because no matter which way you go, there are health consequences. Poverty is a serious driver of disease, and people not being able to go to work is a real problem. So I don't think it's clear cut. But my own bias is that, if we could really implement significant social distancing procedures and mask wearing and get the R0 down below 1 and start controlling this thing, that we would be able to open schools in a matter of months. But I think with what's going on in the country right now, I actually think that this will delay reopening the economy by sending children to school, enhancing the spread, having to shut down the schools, shut down the economy for a longer period of time. So I think the better part of valor to get the economy going is to delay the start of physical schools until we get the R0 down and we see rapidly declining rates of infection.
I hate to cut you off there. I know we could go on for another hour. But John, thank you so much for this relevant conversation. I'm sure a lot of these topics will be brought up throughout the next day or two. If you asked any questions over in the chat, those do save. So we can reach out to John for you. You can reach out to him through the event portal. We have a lot of different networking opportunities. So please keep asking your questions. Please fill out this survey feedback form when you are done with this. And thank you again, John, so much, and we'll see you all in the next session.
Pleasure. Take care. Stay safe.